Hello, good evening, everyone. This is Dr. Ash Khanlashkari, president of MOASC. Thank you, everyone, for spending your Wednesday evening with us as we continue our lung cancer webinar series. Today, we'll be hearing and discussing about the latest updates in the treatment of non-small cell lung cancer, focusing on neoadjuvant therapy. And so this is an area that has undergone quite a bit of change over the last year. And we have, in addition to Dr. Husain, our moderator, who's Associate Professor of Medicine at UC San Diego, we have an esteemed group of panelists today. We have Dr. Andy Jang and Dr. Geena Wu, thoracic surgeon. Dr. Jang is a hematologist, medical oncologist, and Dr. Ye is also a hematologist, medical oncologist, and their practice is primarily in the Kaiser Riverside area, and we're very happy to have them. Dr. Husain, thank you so much for moderating, and I send it to you.
Thank you, Dr. Lashkari, and I'm really actually honored and pleasure to have our panel today with I'm Dr. Jang, who's the leader of thoracic oncology at Kaiser Riverside, Dr. Ye, also at Kaiser Riverside, and Dr. Wu. And I think this is great opportunity to really dissect how early stage disease is being treated and managed. And I think kind of some of the goals of this discussion are going to be really an understanding about what works well, where are there areas for further conversation and discussion, and how we can all kind of learn from each other about this potentially curable state. So again, we're going to focus our discussion in resectable stage 1B, stage 2, and stage 3A non-small cell lung cancer. So with that, actually just have a few slides, and actually Dr. Jang is also going to present some slides. But some of the slides that I'm going to present first are going to just be more to set the stage around this particular subset of disease in lung cancer. So one of the things actually that's really important is that there's been a plethora of clinical investigation in early stage lung cancer. And now we definitely have more of a marriage across a multidisciplinary team, including medical oncologists, thoracic surgeons, and radiation oncologists, to really work together to come up with the best treatment paradigms. I think a central theme is, how are these teams actually being constructed? How are these teams actually functioning? And, how can we learn together about the creation of these teams? I think that's a really important question that some communities are really averse and kind of have been able to form those effectively. And some actually, unfortunately, kind of do have challenges. And I think really dissecting how we can all work together to kind of overcome those challenges, I think, is key. So this is a slide which really shows some of the pivotal trials across the stages. And what we see over here is that for the resectable 1B, 2, and 3A, some of the clinical trials that have been discussed and in some cases led to FDA approvals are those noted here, the Checkmate 816, leading to the neoadjuvant treatment of resectable non-small cell lung cancer. We're going to do a deep dive into Checkmate 816. The Empower 010, leading to the FDA approval of atezolizumab as adjuvant therapy. And then ongoing studies in the adjuvant space, Keynote 091, otherwise known as the Pearl study. For unresectable disease, stage 3, the Pacific study has been a study which has led to FDA approval and actually ongoing use, now showing tails of the curve for the unresectable stage 3 category. This is with consolidation durvalumab. So there are ongoing neoadjuvant studies, and this is a slide which just really capitulates some of the ongoing work in this space. Again, I want to highlight the Checkmate 816. It was a large phase 3 study, 358 patients, stage 1B to 3A. And what we see is that nivolumab plus chemotherapy for 3 cycles versus 3 cycles of chemotherapy, surgery given thereafter, and then really assessing the pathologic response as well as event-free survival, and ultimately going to be overall survival kind of endpoints looked at in this disease and in this trial. The Keynote 671, a study actually that is looking at perioperative pembrolizumab, the pembrolizumab plus chemo for 4 cycles versus placebo. And this is an important consideration is that this is a placebo-controlled study of placebo plus chemo for 4 cycles and then surgery, and then adjuvant pembrolizumab versus placebo for 13 cycles. The Empower 030, which looks at stage 2 to 3A, stage 2 to 3, chemo plus atezo for 4 cycles, also placebo controlled, surgery, and then atezo versus best supportive care. And then the Aegean study looking at 4 cycles durva plus chemo versus placebo plus chemo, and then surgery, and then durvalumab post-therapy. So here's the Checkmate 816. Again, this is the FDA-approved option that we currently have. And again, some key eligibility criteria, and Dr. Jang is going to do more analysis on this specific study in the next series of slides. But again, this is a study that looked at stage 1B to 3A per the 7th edition AGCCC lung cancer screen staging criteria, ECOG performance status 0 to 1. Importantly, no known sensitizing EGFR or ALK alterations in the study. The study was stratified by stage, PD-L1 status, gender. Patients were randomized in a 1-to-1 way between nivolumab plus chemo, nivolumab at 360 milligrams Q3 weeks, and chemotherapy for 3 cycles. And this was in comparison to chemotherapy alone for 3 cycles. Importantly, radiologic restaging, and then surgery within 3 weeks post-treatment. And then, there was some optional adjuvant chemotherapy plus or minus radiation that was allowed, and then follow-up. So some key points is the primary endpoints were pathologic complete response rate, also an event-free survival by blinded independent central review. Some of the key secondary endpoints, major pathologic response, OS, time to death or distant metastasis, and then some key exploratory endpoints, ORR, feasibility of surgery, perioperative and postoperative surgery-related AEs. Importantly, in this study, what's been reported is event-free survival of 31.6 months versus 28.6 months in the control arm, hazard ratio 0.63. Pre-specified interim OS showed a hazard ratio of 0.57. And the pathologic complete response improved. The data on the adjuvant optional chemo radiation is not fully available as yet. So here shows, some of the event-free survival endpoints. Again, at 12 months, 76% event-free survival versus 63%. And then at about 24 months, 63.8%, 45.3%. On the top, we have the pathologic complete response rate. You can see really a dramatic pathologic complete response rate. And stage 1B was about 40%, stage 2A, 23%, stage 2B, 24%, and 3A, 23%. So maybe actually I'll stop over here, and then Dr. Jang, I'll let you share your screen because you were going to show an update from ESMO on the chip.
Yes, yeah, okay. What I want to do is I want to basically give some ESMO update in 2022. So a lot of stuff I'm going to show is quite new. I probably just only 2 weeks old, and I want to also show the audience this is. We know the checkmate A16 right now is a standard, and we want to know whether there's any other options or what are the data out there. So I'm going to be showing IO chemoradiation, and finally I'm going to show the newest detailed analysis on checkmate A16. And we can, after I present all those data, then we can open up to discussion. All right. So can you see my slide?
Yes.
Okay. So I'm going to show 4 trials here, and the first trial that I'm going to be showing is so the question I want to find out is, what about single agent IO? Can we use a single agent IO in the neoadjuvant space in non-small cell lung cancers? And this was published in Nature Medicine probably just 2-3 weeks ago. 183 patients. Okay, basically everyone gets majority gets 2 cycles of atezolizumab followed by surgery. But what's interesting about this trial is that they do not know the EGFRL prior to the surgery, but once they knew it, on the back end, they will exclude the 9% of EGFRL positive patients, and they will analyze the 80% of patients who is EGFRL negative. Another interesting part about this trial is they are actually allowing adjuvant atezolizumab and other therapies in the adjuvant setting, which wasn't really published in the checkmate A16. So in this trial, this is a phase 2. Again, is 1B to 3B, 2-cycle neoadjuvant atezo, day 1 and day 22. And the surgery is within day 40 and plus minus 10 days. Again, EGFRL are excluded from the primary analysis, but at the time of surgery, they got 10% of the patient who has EGFRL positive. What they found out is that they got a major pathological response about 20%, but their PCR is about 6%. Their definition of MPR is less than 10% of viable tumor cells. So what this trial really showed us is, well, I think single agent IO definitely has its activity, but the PCR rate may not be good enough in par with the checkmate A16. The most common adverse event is fatigue, 39%, procedural pain is about 29%. Immune-related AE is about 41%, but nothing really high in grade 3/4 here. Another interesting part about this trial is actually there's exploratory analysis that the investigator actually using 14 different panels of innate immune cells, and they try to predict whether the patient will respond to IO therapy. So I thought that's quite interesting, but I think a lot more work to be done in this setting to predict the future of who's a patient who's going to respond to single agent IO. Now moving on, this is ESMO 2022, the Neo-Predict Lung clinical trials. This is actually quite interesting because we knew, in the melanoma space that the Nivo-Rela has been approved in the frontline melanomas. So this is basically try to use Nivo-Rela. Rela is an anti-LAG3 antibody in neoadjuvant space. So I consider this as an IO therapy in neoadjuvant space. And this is so what they did is they gave 30 patients in each arm. One arm is getting 2 doses of nivolumab. The other 30 patients are getting Nivo and Rela and 2 doses, and then followed by surgery. And this is again 1B to 3A patients. And after that is a standard care adjuvant therapies. What's interesting about this trial, in my opinion, is the Rela or anti-LAG3 probably does not add too much in the complete pathological response, 30% versus 27% here. But the thing is, the feasibility of surgery is 100% in both arms. So what this trial at least tell me is that, and this my opinion is IOIO could be a potential option, but we need to figure out who's a patient who can really benefit. But this is just came out from the ESMO 2022. So another thing about the Neo-Predict trial is a similar response among various histology in non-small cell lung cancers. Again, no new safety signal. We pretty much know how to do this drug in melanomas. So this is nothing surprise to us. Another thing they notice is there's increased peripheral effector T cells on those who basically has responded. Now moving on, to another ESMO 2022 Neo-Adjuvant trial, the INCREASE trial. This is actually quite interesting in my opinion, because this is kind of try to do a bit different, maybe a slight variation of Pacific 2, except we're going to incorporate surgery. So the schema on the INCREASE trial is that, it's a T3/4 N0 to 2, so it's non-small cell lung cancers. But what's interesting about this schema is that actually you give Nivo-EP on day 1 and you give Nivo on day 22. So we're using IOIOs or concurrently with chemoradiation. So we're getting the standard chemoradiation, but we're adding IOIOs. And then after 6 weeks is surgical resection and follow-up. And so what I think what's interesting about this trial is that they're actually able to find a 63% pathological complete response rate, which is quite impressive in my opinion. The major pathological response rate is close to 80%. And 24 out of 27 patients are actually able to proceed with surgery. So this is quite high pathological response. But if you look at this graph, the waterfall plot, which I have noticed is, do you notice that if the patient has some kind of driver mutations, like EGFR, CK11, ERB, and NRAS in here, their response actually lower. So it kind of sends me a message is, if I have a patient with driver mutation doing this approach, I'm probably not going to expect 100% response here. That's at least what I take from this. But this is quite interesting because this is probably the highest PCR that we have seen, at least in the neoadjuvant space. Now, finally, since we discussed about CheckMate 816, is there anything new that coming out of CheckMate 816? Actually, ESMO 2022 has done a further analysis on CheckMate 816. So this is what I want to kind of discuss about. Dr. Husain already discussed pretty much what the CheckMate 816 is. The key number is pathological response is 24% versus 2.2%. And this is basically improved EFS, and this is the only FDA approval therapy that we have right now. Now, moving on is, the first thing that the ESMO 2022 show is that whether the patient have lymph node involvement or whether the patient without lymph node involvement, their benefit is very similar. You can see that median EFS 31.6 months versus close to 30 months without lymph node involvement. The hazard ratio is very similar, around 0.7. So the first message that this further analysis tells us that in CheckMate 816, whether you have a patient with lymph node involvement or without lymph node involvement, their EFS is probably going to be quite, the benefit of EFS is probably quite similar. But one thing I do want to say is, if you look at the bottom part is, patient without lymph node involvement, the pathological complete response is 40%. I think that's, at least that's a take-home message that I got from this. Patient with lymph node involvement, the pathological response rate is only 19%. So we know that if you have a lymph node without lymph node involvement, you're going to probably do better with CheckMate 816 or chemo IO. Now, another thing that they have found, they had discovered, really, they try to look at this. They try to look at the primary tumor response and the lymph node response. So what they try to show is, you can see that 19% the dark blue area. If you got a patient who has primary tumor response and that has no residual there, and you got a patient who also had lymph node response and there's no residual there, you are going to get a highest benefit from the EFS standpoint. So that's the first thing that they discover. And the second thing is, obviously, if you have primary tumor response and or one or the other, okay, you did not have 2 out of 2, you only have 1 out of 2, you are the second best. But if you obviously you don't have any responses in the primary tumor or the lymph node, you are doing the worst. Okay, so that's the second message that was reported in ESMO 22 in Checkmate 816. And again, similar ish. They just want to show the similar EFS. Again, the point is, it's crucial to have primary tumor response and also lymph node response to get the best result. Now, my take on this is they have a similar efficacy in EFS, but PCR is higher in patients with negative lymph node involvement, 40% versus 19%. And the best EFS in patient with 2 out of 2 means 0 RVT, 0 residual tumor volume, and 0 negative lymph node at surgery. Your EFS is 92% in 2 years, which is quite high. So that made me think about is, well, what about the patient who has high lymph node volume to begin with? Let's say you got a patient with N2 disease, you're gonna try to give them a Checkmate 816. Their probability of getting to that point is 2 out of 2 negative is probably not as high. So the way I'm thinking about is perhaps those are the patients we might have to think of other modality, maybe using the increased, style, with chemo RT plus IO. So at least that's kind of what I'm thinking about, but this is something just came out of ASCO. So finally, my final slide is that, again, Checkmate 816 remains a standard of care, and it is the only FDA-approved approach at this time. And like what I mentioned is, the N2 disease, a high-volume lymph node, do we need to be more aggressive? The second thing is we knew that there is a clear activity in IO and IO-lag approach, but I think we are not really sure what is the optimal cycle to achieve a higher PCR. Right now, it does appear that the PCR in the single-agent IO is probably not going to be high enough. Do we really need to add chemotherapy to increase the pathological response? Unclear, but we do see that that's what happened if you add, chemo or chemoradiation. And then finally, I want to see whether the investigator can come up with more tumor profile to predict a response rate like the first trial I presented in the Atezo trial. Now, finally, I thought the tri-modality appeared to be very promising. Chemo IO was concurrent with chemoradiation. But the issue is, which is better, Increase versus the Pacific 2? These are the two trials. Pacific 2 is the concurrent chemoradiation, but they are moving the value map upfront rather than doing sequentially. So that's actually very eager to see that, and to see whether surgery is required in neo-adjuvant modalities. So that's what I have today.
Those are excellent points, Dr. Jang. I think really very critical review of the pros and the cons, and even just some very kind of important nuances here as we interpret the data, both from Checkmate 816 as well as some of the other evolving therapies. Mm-hmm. I think with that, actually, I'm going to share my screen again, because these types of questions raise some important points that I think that as a field would be good to reflect upon and maybe kind of turn to our panel. And so one of the things actually, let's just kind of take this first point as well, is may I ask, actually, at Kaiser Riverside now, how many patients are you guys currently treating with neoadjuvant IO? And I may actually ask Dr. Wu as well, kind of that dynamic between, from a surgery perspective, as well as medical oncology perspective. How are you guys discussing that at Kaiser right now?
Well, I can say, first of all, we haven't done any patients using the new neoadjuvant IO. And part of it is just, we haven't identified any patients. We had a couple potential patients, but I think some of them were just not surgical candidates because they were elderly, frail. But we do have a lung conference, like kind of a tumor board that we do once a week. And it's very well attended by our pulmonologists, oncologists, our radiology, myself. And that's kind of the forum where we bring up these patients, and would be the place where we would identify someone who is a potential candidate that we would refer for, neoadjuvant, and then, followed by surgery. But, it's something that you everybody has to look at together up front and make a decision before, sending the patient for, committing the patient to kind of the route to go. And then I also, on our surgical side, our regional thoracic surgeon. So, I work at Kaiser Riverside, but there's a thoracic surgeon at many Kaisers across the Southern California. There's 8 of us, and we meet twice a month and we go over cases, and we talk about things that, we would recommend or do amongst ourselves, because we're just one surgeon at one medical center, and then we kind of have the expertise of I would say my partners in the region. And so if we identify a patient like this, we would bring up, are they a candidate for neoadjuvant IO? And, if, they are eligible, then, we go down that route. But I have not asked them if any of them have treated a patient with this, because, this is still all fairly new data. And, some of us are wondering, for the 1B patients, do we wait for neoadjuvant IO, or do we just take them straight for resection? Because, there's the fear of delaying the patient's surgery for neoadjuvant therapy. So that's my take on it.
I think that's an excellent, segue. And I may actually just also ask you just a quick follow-up question on that is, as a thoracic surgeon, when you hear about, kind of all of these trials, right, that both myself and Dr. Jang has presented, how is that being processed by the thoracic surgery field? It's something kind of would be great for us as medical oncologists to hear this. Is it something that kind of is just seen as, wow, this is like so detailed and so nuanced and things, but like, how do you view that now as a field?
Yeah, I think, it's all very new, and there's really no good long-term data. And then just what Dr. Jang presented about the lymph node burden. If, obviously someone who has bulky N2, multi-station nodal disease is not going to do as well as someone with, isolated, N2 disease or N1 disease. And so we kind of question, and like, how much is the patient really going to benefit from this? And so, kind of our take on it is, it doesn't necessarily change our practice unless it's a stage 3A patient, or it's someone who is questionably resectable. In which case, then we bring in oncology to discuss neoadjuvant. But like I said, I think in our group, we talk about the data, but our inclination is to still take a 1B patient to surgery, because that can happen quicker than, sending them for neoadjuvant therapy and then waiting, rescanning, and then bring them back for surgery. So that was kind of our discussion, because we did talk about this paper in our group a while ago. But it really doesn't come into play, I think, unless it's 3A disease, because 3A disease, it's definitely not someone we would take to surgery up front. It's, they're going to have some neoadjuvant therapy, and that is really up to the oncologist. So we kind of defer to them to make the best decision about what kind of therapy to put them on.
Really important points, actually, and really insightful. That actually goes into this next question, which for some of these patients with stage 3 disease, and again, stage 3 can sometimes be difficult to understand resectability. In a previous kind of discussion, we spent a lot of time kind of with our thoracic surgeon here at UC San Diego, Dr. Boyes, kind of really assessing how do we diagnose resectability. Do any of these trials and such change how you think through what may be resectable versus potentially resectable? Kind of the patients that would otherwise be deemed unresectable, now in light of Checkmate 816 and neoadjuvant approaches, that both Dr. Jang and myself kind of mentioned, with even Dr. Jang has mentioned, the increased study kind of with chemoradiation, and such, does that change how you approach resectability?
I think that's case dependent. And, like you said, it really takes a surgeon experience and reviewing images. And a lot of times, getting my partners involved because, I'm the youngest in the group and, they have way more experience than I do. If there's someone that I think is borderline or questionable, I would bring the patient up to that forum and ask them, hey, would anyone consider resection? And then you don't know what the response is going to be to the neoadjuvant therapy. But I mean, if it's a great response and it converts someone who, otherwise would have needed a pneumonectomy to someone that could just have a lobectomy, then yeah, I think that totally is a game changer. But neoadjuvant therapy, I don't think is new. It's the neoadjuvant IO that's new. Then, we, even before this trial for, borderline resectable patients, we were sending them for neoadjuvant chemo. And we rarely actually send for radiation unless it's a question of like chest wall invasion or just, we really need to reduce the size of the tumor. But if it's just lymph node involvement, we oftentimes just send people for chemo, neoadjuvant chemo. And they always, get some sort of partial response, and then we take them to surgery. But patients that, have bulky multi-station N2 disease, that's someone that we sort of hesitate on committing to, neoadjuvant followed by surgery, just because we know they don't do well. And, you would have to see what their response is to the treatment. But if they had neoadjuvant, let's say chemo, and they still had residual nodal disease, are you still going to take them for resection? Because how well can you clean out those lymph nodes, and can you ensure that you got it all? So yeah, the IO would be, game changer, because then, what if, they had a complete pathologic response? Would you deny that patient surgery? Those are all good questions. And I think we need more patients to start doing these and see what the outcome and, the response is, to really answer some of these questions. And then we all know that, patients who get immunotherapy, their surgery is just a little bit stickier, I would say, not undoable, but, definitely not like virgin tissue or someone who, hasn't had therapy. And so that also comes into play. And, having operated on someone who had done immunotherapy, I kind of know, like, it's, it's not quite the same as someone who's never had treatment. Things are a little bit stickier. It's still doable, but, it takes a little bit longer, a little more patience and dissection on our side. But for the benefit for the survival benefit in the patient, it would definitely be worth it.
Really important points. I was having a discussion with, with someone else actually about that point that you'd mentioned about, this concept of perhaps the surgery is harder post-immune therapy. And if that's the case, is the thoracic surgery field going to perhaps kind of view it as, if it's harder, let's steer away from it, versus if it's harder, are we going to still kind of continue to, amplify the experience, try to kind of get, I guess, more used to or adept at kind of doing it.
Right.
Among your colleagues, like, how do you feel that sentiment is being evaluated? Is it something kind of where, people kind of look at prior treatment with immune therapy and say, gosh, like, this is going to be more difficult? Or is it kind of up for the challenge kind of scenario of taking on these cases?
I think it's definitely up for the challenge because, there's very little, I think, short of it being, unresectable, which you try to make that determination up front. But, if things are hard, you open, not everything has to be minimally invasive. A better surgery, a better cancer surgery for the patient is better than, trying to stick with little incisions. And so, you open if you need to, but, it's very much, I think, we're up to the challenge as long as there's data that shows benefit and outcome. So, I mean, you don't want to take everyone if it makes no difference in terms of their outcome. But I mean, for, taking another cancer, for example, esophageal cancer, we do esophagectomies for esophageal cancer. And, the treatment, standard of care treatment is neoadjuvant chemoradiation, followed by surgery. That's, well documented based on the cross trial for esophageal cancer. And that's neoadjuvant chemoradiation. And we know what radiation does for surgery. And, nobody wants to operate in a previously radiated field, but there's documented benefit to survival for patients. And so we do it because it's good for the patients. I think it's kind of the same thing for this. If the patients will benefit from this, then we're up for the challenge.
Super, super insightful, super interesting. As medical oncologists, it's always great to hear, your vantage point, representing kind of the voice perhaps of thoracic surgery in that regard. But I will just hone on one other point that you mentioned about the clinical benefit, right? And, how people assess clinical benefit. So this last question that I have over here is path CR, right? And what is the right endpoint that you view as a thoracic surgeon that you feel carries the most weight for an individual patient? What would you say, kind of if you were to align with, what would be that right endpoint to keep looking at?
Yeah, I mean, probably just to very generically say like overall survival or disease-free survival was probably more specific. I mean, the pathologic complete response, I mean, we get that in esophageal cancer too, but it's a minority. It's a 25% minority will get a complete pathologic response. That means 75% don't. So, that's something you figure out after the resection, because you're not gonna, bank on pathologic response by imaging or, like biopsy or something like that. You really have to do the resection to find it. And pathologic response is great. If they get it, then, they're going to have better outcomes. But I think, we want, 5-year disease-free survival, 5-year overall survival. That's, better in these patients with the neoadjuvant therapy. I think that will truly, kind of push us to really go for this, even in the 1B patients potentially. But I think, it's just going to take time because, you have to have the time to hit the 5-year mark and to show that there is actual benefit for these patients. But yeah, I think in my mind, showing disease-free survival or, overall survival in the manner that it currently is, but I think, at 2-year survival, but extend it longer, 5-year, 10-year survival. Because we know early stage lung cancer, the 1A patients do better than the 1B patients, and even the 1A, 1, 2, and 3 do better, the earlier stage it is. And that's kind of reflecting what Dr. Jang presented is that, the less lymph node burden, the better they're going to do, obviously, or, the more likely they're going to have a good response. And so, like the question thing, I think here, which I've sort of gotten from the discussion is who really is going to benefit from this and who, we're trying to select for who are the patients that we should do this for. Because, not everyone is, potentially going to benefit from this.
And maybe I'll turn it over to Dr. Ye, actually. Dr. Ye, it would be great to hear your vantage point, kind of, and maybe perhaps kind of within your group at Kaiser, how do you and Dr. Wu and Dr. Jang, kind of come together to kind of say, this is the right patient, go for this patient, or don't go for this.
I don't think there's a cookie cutter method here. I think it's all case by case, whether patient's resectable or not, or is the patient fit enough for surgery. Obviously, things are changing and the data are kind of piecemeal. You got the iron power study with the adjuvant lung cancer stage 2 and above. And then you got this Neo-Adjuvant checkmate A16. So it's like they're conflicting. So do you do surgery upfront and followed by the Empower study 010, or do you use the checkmate A16? That's the kind of like the $1 million question. And I think there's a couple of trials that we have that's probably going to answer that, where we're going to have chemo plus immunotherapy upfront, followed by surgery, followed by immunotherapy. But right now, there are some unanswered questions. You know, do you do neoadjuvant or do you do surgery followed by neoadjuvant? Because the A16 doesn't really answer whether the patient needs adjuvant chemo afterwards. And what do you do for the patient that don't achieve CR? You know, what happened to the 75% of patients that don't achieve CR? What do you do? I think that's the biggest question. And I think that's kind of the dilemma at this point. You know, if they don't achieve CR, what do you do? Do you just wait tight or do you do additional treatment? And if you do, what do you do? I think that's a question that I don't think anybody knows. But if you follow the A16, you basically just observe. I mean, you have option to do chemo, but we don't know if those patients benefit from it. So I think that's right now, I think things are moving toward neoadjuvant. But once we have more studies, like the one you mentioned, the neoadjuvant, the newer adjuvant, where they have the adjuvant therapy, the neoadjuvant and the adjuvant therapy afterwards, I think that will really answer that question. What is the best approach? Like the Empower 030 and then the checkmate 671, that will really answer the question. And if that's a positive study, I think our approach in the future is going to move to neoadjuvant.
No, super interesting. Really, really interesting points. I just noticed in the chat that Dr. Lashkari had a question about the complete pathologic response. Was that higher at earlier stages? Over here, this figure that I showed before does show that at stage 1B, the pathologic complete response rate was higher than as you escalate the stages. But importantly, though, the pathologic complete response rate stayed about 23 to 24% across stage 2A to 3A. And so that was, an interesting point there. I think one thing that's interesting is the field, and Dr. Ye kind of spoke to this point that perhaps, the data in the adjuvant and this data in the neoadjuvant, there's there's different ways that patients come into a surgical decision, right? And Dr. Wu kind of mentioned this too, is that, perhaps kind of for stage 1B or, some patients, those patients are just taken to surgery. And I will tell you in our practice, I've had a number of patients in which we've used 816. And
sorry, I think, did you, I really want to ask the panel and also you and maybe some non-experts on your discussion point number 2. I don't know whether you have discussed that yet on the discussion point number 2. The balance Pacific versus checkmate A16. To me, that's like $1 million question because, as you know, the controversial about Pacific is that, as you know, the label in the United States is regardless of PD-L1 expression. However, as you know, a lot of lung people, they are not recommending adjuvant durvalumab in patients with negative PD-L1 because the further explore analysis show there is no overall survival benefit in PD-L1 negative patients. That's why in Europe, Pacific is only approved, I believe, correct me if I'm wrong, in the PD-L1 1% or higher. So that's the first thing is, if I'm going to use a Pacific, do I need to check a PD-L1 expression? We know checkmate A16, you don't need it. But if I'm going to do the neoadjuvant approach, I guess I don't need it. But if I'm going to use the concurrent chemo RT followed by durvalumab, do you use a PD-L1 expression as a cutoff? Number one. Number two is, although PD-L1 negative patient has no no overall survival benefit, but there is a progression-free survival benefit or hazard ratio of about 0.7. Is that enough for us to do it for everybody? So I think that's a really good discussion among the experts. What are you doing here?
Yeah, no, really, really excellent point.
Mhm.
In our practice, we have not limited the consolidation durva for the unresectable stage 3 based on PDL1. But I am aware and kind of knowledgeable about that controversy there for those patients. And I think there is some nuance we have for the EGFR cohort, partly because one of the concerns we have in the EGFR cohort is that if patients get consolidation durva and then, need to get a TKI post the durva or during, kind of immediately after the durva, that's kind of a concern around toxicity. And so those are certain populations, but we've not limited consolidation durva to the PD-L1 expressing patients. But I think you're right, though. This is an important question because what I see one of the biggest areas for discussion and what I've seen in our practice here at UCSD is that this concept of resectability has become a little bit more fluid. And it's become a little bit more fluid in the context of the fact that what may be borderline resectable, at least in our group, is being reevaluated after treatment with the hope and kind of proposition that the treatment can make it resectable. And I think that, for some degree, those patients under different circumstances may have been considered unresectable, right? And I think that's why I think Dr. Wu's point was a really good one to say neoadjuvant therapy is not a new thing per se. It's the neoadjuvant IO component of it. And, but I do notice that in our practice, we are using more neoadjuvant therapy as a whole more than ever. And I think this is why it's a great discussion to have as a multidisciplinary team, right? Because, previously, if I look at my practice, the number of patients that I have that are early stage now are dramatically higher than, than there were in previous years. So I do think actually that, early stage patients are becoming a center focus for medical oncologists as well as, and I think the discussions with thoracic surgeons is great. I think going back to this concept of who makes the decision though, on who should get neoadjuvant therapy. And I will actually maybe turn it back to you, Dr. Wu, in that sense, is that when you see a patient, firstly, and you say, the patient stage 1B, let's just remove it and we can consider adjuvant therapy depending on what the pathology is with the resection, or how often are you going to this multidisciplinary group and kind of saying, should we do neoadjuvant approach even for a 1B?
I think if the patient came up that, like a stage 2 and, then I would definitely probably consider a stage 2 for neoadjuvant IO. For the 1Bs, I don't know, because it's really only 4 centimeters or greater. And I was actually curious to hear because you were starting to say that you had some patients that were 1B that you have, put through this, algorithm. And I mean, that's obviously a decision you make with the surgeon. And, I guess they were agreeable to, allowing the neoadjuvant IO to proceed and then follow-up scanning and then resect, or was it a question of the patient was unresectable?
Yeah, so I have one patient,
Okay.
kind of who is 1B who did go through 816.
Mhm.
And the tumor was, I think it was like 5.5 or, kind of, so it wasn't necessarily just like 4.2 centimeters, or something like that.
Okay.
But I will tell you this, is that I've also had patients who in our same surgery group have have been, stage 1B and taken straight to surgery.
Uh-huh.
And so I do think actually that decision in that cohort, meaning, stage 1B, probably more falls into the surgeon's decision.
Right. Right.
On-
Well, 'cause,
on
I mean,
where-
it comes to you and, but I mean, it is of the, I think it's on the surgeon to present the options because, you have to give the patients the options. I mean, one of the most important things of my discussion with the patient when I talk to them about surgery is alternatives. And, every early stage patient that I speak to, I bring up SBRT radiation because that's an alternative. And it would be, my fault and, to the patients, not doing my job if I don't give them the alternatives because, I'm a surgeon, I want to do surgery, but if they don't want surgery or they would prefer to do radiation, I have to give them that option. So this kind of falls in that same practice where you would want to present them with the option of, hey, we have this new data, there's another way we could go. But I think a lot of patients will just want their surgery. They, want to go through the trouble of having.
I think for 1B purposes.
Therapy. Yeah, and then have surgery. It's like they think of it as a delay. They just kind of want it out. So it's kind of also patient preference in some ways, because this is new, exciting, and early data. What is the benefit? And so we don't have that information for them, and so. You're right. The early 1Bs, and because a lot of our referrals come from the pulmonologist, they'll just send to me directly, and I won't necessarily send it to oncology if it's something that's just easily resectable, like a 4-centimeter tumor, no lymph nodes. I could just take them straight to surgery. But I talked to Dr. Jang, and I told him, like, any patient that could potentially get this, I will, we'll talk about it. Like, I won't just take them straight to surgery. I haven't had a patient like that. Well, I had a couple patients that I brought up, but they weren't really candidates. So, so the other thing I was thinking was, there are patients where, because, like you said, they have a disease, or for whatever reason they're unresectable, maybe not because of the tumor itself, but because of the patient, because they have poor lung function and you're trying to preserve their lung. And let's say they have like a 3-4 centimeter tumor, and you want to try to preserve lung by doing a segment. You want to put them through the Neo-Adjuvant IO to see if it'll shrink the tumor to the point where maybe you could do a segmentectomy versus a lobectomy. Since the patient wasn't a candidate. And, you can amplify that same scenario and say, okay, well, with the large tumor, you would have had to do a pneumonectomy. The patient wouldn't have tolerated it. But that now you do neoadjuvant IO, it's now smaller and they can do a lobectomy. So that's like kind of the ideal scenario where this would be perfect. But unfortunately, I haven't come across that yet.
I would say for 1B patients, for me, is that if right now the data appear to be stronger in surgery followed by adjuvant atezo. The reason why is the Warlong reason is just updated that the Empower 1.0 the overall survival data, although still premature, but it appeared that the curve continued to separate, and most likely they will have an overall survival benefit coming up. So in 1B patient, if I have a PD-L1 greater than 50%, I'm definitely going to go with surgery followed by adjuvant atezo. For especially in the high PD-L1 patient, because that's where the benefit comes from. If you have a PD-L1 like 1 or 2 or like less than 10%, you're not going to get too much benefit from adjuvant atezo. So that patient you could entertaining doing the checkmate 816. So right now, based on the evidence, I think overall survival data is probably going to be more mature in the Empower 1.0.
I think you mean stage 2, because Empower 010 is 2 to 3, not 1B.
Yeah, 1B was, right now it's going to be a 2A because of new staging. But when they initially do the study, it was AJCC 7, so it was 1B. But now it's 2A. Yeah,
that makes sense.
Really important points, and I think it's amazing to see how close you guys are to kind of making these decisions together. I think super interesting. I think one thing I've appreciated in our practice over here in San Diego is that And I do think that this is, kind of sounding similar with what you're saying, Dr. Wu, as well, is that for the stage 1Bs, that's something that, really, kind of that decision kind of really falls with the surgeon, kind of in some cases making that without seeing medical oncology. For the stage 2, we generally do all, come together and kind of, most of those patients are offered a neoadjuvant approach. I think one thing that has resonated with our group quite robustly is that the applicability of immune therapy when the tumor is intact, may have, at least in preclinical models, has been shown to, because the neoantigens are there, the tumor is intact, that the immune system may be in a better position compared to if the tumor were removed, and then adjuvant IO given. And so I think that has resonated, with our group as a whole, that concept, and I think patients do, see that as well and see that logic. But I do agree with you, Dr. Wu, when you said that patients want it out, and in many cases, patients are anxious during this process. I have 2 patients who, just this last week completed the, the 3rd cycle of Neo-Adjuvant 816, and then actually were scheduled this month to do their surgery. One patient, right after finishing the 3rd cycle, was on the phone saying, "When is my surgery date? How can I get this thing out ASAP?" And our surgeon, who was working on these cases, Dr. Boys, he had given a date for, this month, at the end of the month. And so the patient said, no, we want to do it much sooner. And so he said, well, and so patients do want to get this out ASAP, and perhaps even faster than what the surgeons necessarily kind of, want necessarily. But one way we've been able to kind of really talk patients through and kind of get patients through this is by getting scans through the process. And I think when patients see the cancer shrinking in the neoadjuvant state, that is also very reassuring for people.
Right.
Yeah. And so that's been one thing I've been impressed with, just how a patient's mood and tone and, situation kind of evolves through this process of neoadjuvant, in that. So I think that's kind of been an observation that I've made as well.
So Dr. Husain, so I like your approach that, shifting that way, and I agree with you, but what do you do after this post-op setting where they still have disease, residual disease? Do you watch, or what do you do?
So I think that's a really excellent question. And I think one thing that I'm really eager to get more info on, from perhaps a future update of Checkmate, 816, is this comment on whether or not, like, how people did with the adjuvant optional therapies that could be given after. Because in spirit, Dr. Yag, I agree with you in your prior comment around what is the value of the post-surgical treatment, for some of these other trials. And I think that is an important unmet need. I think we'll have to see how some of these other trials play out in the post-surgical component of it. I also think actually that, unfortunately, when we think about, and I was going to present this slide as well, this is the adjuvant studies in non-small cell lung cancer using IO. Obviously there's diverse agents, right? Obviously Empower 010 is the one that's FDA approved now. But then there's, that study we mentioned, Keynote 091, otherwise known as the Pearls, kind of, which has presented data on Anvil, which is nivolumab, adjuvant therapy. And also, there's durvalumab data in this space with, diverse endpoints, mainly actually being DFS, actually with the Anvil nivolumab study having both DFS and OS. But I bring up this point actually just to make the comment that all of these studies randomized to IO post-chemo in the adjuvant setting. There is and I'm aware of an ECOG study that is looking at the IO plus chemo post, after surgery. And, really, when you think about kind of where that is as well, I guess one of the questions comes up is that, how would that data also look? So I think that, there's some important components there across each of these points. So we'll just have to see with further iterations how this goes. But I kind of agree with you that, so far I haven't been in the circumstance of like in right now, for these patients who we have who have gotten 816, we are following the approval of the 3 cycles surgery and stop adjuvant therapy report based on whether or not there's any residual disease, or positive margin, component. But I do think actually that the question about where do people fall in this continuum here, I think that is a really important question. There are patients, though, that I will tell you this, as I've presented 816 to patients, the concept of receiving 3 cycles and being done is powerful for some people. I've heard Dr. Jang speak about that as well. I think, Dr. Jang, you are a big fan of the fact actually that people are done after receiving the 3 cycles, rather than having to go on for, year of therapy or such, right? What do you think about that, Dr. Jang?
Right now, my thinking has somewhat of shifting because I just presented the further exploratory analysis on the checkmate 816. Now we know that if your primary tumor or the lymph node did not get a PCR, your event-free survival is going to be inferior. So those are the patients that definitely will consider adjuvant therapy. The drug of choice, at least for me, is going to be adjuvant atezo at this point, mimicking the IMpower 10. For those patients who either do not have a tumor PCR or the lymph node still positive, I know they are the bad actor. I know from the checkmate 816, their event-free survival is going to be absolutely the inferior one. So I would do something further for those patients. Now, on the other hand, patient who has 2 out of 2, like the complete PCR, lymph node was positive before, but now it's negative, primary tumor, complete response, they're going to do well. So those are the patients I will choose to observation.
Yeah, so that's the $1 million question. What do you do post-op? Is it more immunotherapy or more chemo or combination or chemo radiation? I don't think anybody knows.
I will tell you this. So I just had this discussion with one patient who literally just got his surgery on Friday and is leaving the hospital. And I saw him in the hospital, and I said that one of the advantages is you're kind of done right now. Right. And he was very, happy about that, about being done with everything. So I think, obviously evolving concept, we'll see how things play out, with these other studies, as well, that gave the adjuvant, IO, and kind of see how they play out. I think we are
Dr. Husain,
Uh-huh.
Dr. Husain, can I ask you a question regarding this slide? In these other trials, in the Keynote, Empower, and Aegean, are these double randomizations? In other words, do the patients after surgery get randomized again?
No, so
they just continue. If they were getting the immunotherapy with the chemo, they'll continue in the adjuvant setting or post-operative setting.
I believe that's the case. I do have to double check that, but I believe that they just continue on. So, Dr. Lascar, you bring up such an excellent point as well. Again, I will double check this, but, how crossover, so this is an important point that when we look at overall survival, and Dr. Wu had mentioned this, that overall survival is the key, right? Overall survival also takes into consideration whether or not a patient gets retreated in the future at progression or kind of other things, right? And so how that also plays out in this scenario may have some important distinctions and influences. So we'll just have to see how that plays out as well. the role of crossover in the scenario. So maybe with that, actually, I think we have gone over a little bit, but just wanted to kind of firstly thank you all. Your insights are hugely appreciative. And also kind of, Dr. Jang, thank you so much for your review of the ESMO, really important novel things. I think we have to keep our eye on for LAG3, obviously because it's being explored in the metastatic setting as well. And we need better biomarkers, and studies like the one that you mentioned provide an opportunity to kind of really understand some of the correlative work, the post-tissue or the pre-treated tissue, that's resected. And obviously, kind of as things evolve with chemoradiation and then surgery, the triple modality therapies, we'll have to see how those evolve. So once again, thank you all. And actually, Dr. Lascari, I'll leave it.
Thank you. Now I'll just wrap it up and say thank you to you, Dr. Husain, Dr. Wu, Dr. Jang, Dr. Ye. Thank you guys all for joining us. And we look forward to our next meeting next month, where we'll focus on lung cancer screening. Everyone have a good evening. Thank you, guys.
Thank you.
Bye-bye.